Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. We are happy to have you tune in with us today. We have special guest Taryn Lee, and your background knowledge today will be about implementing change into practice. Welcome, Taryn.
Hi, Derek. Thank you so much for inviting me on today. I appreciate it.
Yeah, thanks for coming on. You mind introduce yourself and tell the audience a little bit about you?
Yeah, absolutely. My name is Taryn Lee, as Derek so kindly introduced me. I am a doctor of nursing practice, and I have my F&P certification. My background has primarily been in emergency and infusion nursing, and I've really fallen in love in infusion in the last, probably 7 or 8 years. So I hold certifications in infusion nursing and vascular access, as well as risk management.
Fantastic. Very diverse background. It's wonderful to see. But currently, you are in leadership now. Talk about that.
Yeah, absolutely. My current role is Director of Clinical Support, both with Dynamic Access and Dynamic Infusion. So one side of our company helps with vascular access services, and the other side does home infusion therapy.
Talk a little bit more about the organization. You have multiple service lines within that organization?
We do. So our vascular access side provides ultrasound guided access for peripheral IVs, midlines, PICC line therapy, and we serve patients in long-term care units, rehabs, and acute care in a variety of states at this point. We recently fell into the home infusion therapy world as well and have just exploded in that arena. So we do mostly chronic, but some acute therapies with home infusion. And last I heard, I think we're in 22 states at this point. So very, very exciting. Last year, a ton of growth, and in case in point, a ton of change in the organization in our infusion side recently.
So yeah, I can imagine tons of change, but really talking about your clinical support role, you manage all the clinical components to those service lines. Is that correct?
I do. It's been challenging, but it's been a lot of fun. So infusion has always been my background. I have a little bit of vascular access experience when I worked in the emergency room, 10 years ago. But I started with primarily a background in infusion and had to kind of gain a lot of knowledge quickly for our vascular access side. Luckily, everyone has been so willing to help me learn and so available for any questions. But the infusion side has really been my passion for a long time. So I was very excited to be invited on this podcast.
And you do all the changes for practice within the organization.
Yeah.
You implement the changes. You are that person that's really guiding those changes and keeping everything relevant and up to date, right?
That is the best part of my job. That is the most exciting thing that I do. I have always been passionate about evidence-based practice. I think we all are as nurses. You know, we want to do better for our patients and we want to guide change. And in addition to that, I've always been an absolute nerd. I love reading new articles. I love seeing updates in our practice and what is new in the field and what we can change and do differently about our organization. So my favorite part of my job is that I get to take a look at the amazing people who've done education and research in our industry and in both my service lines industries and see what we can adapt our change to and what we can do differently with our own organization to really make a difference in our patients and our quality of care. So I absolutely love it.
So define change within practice. What does change within practice mean to you?
Let's see. Change in practice to me means continually evolving our methods for care. We need to take a look at what we are doing, the services we are providing, the practices, the processes, the protocols we have in place, and evaluating it against current practices and current evidence, current standards and strategies, and make a decision. Is this something that we are aligned with in our practices, or is this something that we need to develop new protocols for, and take a look at what we're doing to see if we need to move on and progress within the field. So for me, the concept of change is a necessity. You have to progress. You have to move on, especially in healthcare. I mean, think of what we were doing when you first started nursing, just in the short period of time, how much has changed for us.
It's
So
strange.
yeah.
It's strange to reflect on and really see all the advancements and see how versatile nurses have to be and flexible to move with a change in profession and all the things that come with it. So you're 100% correct. And, I didn't ask you, and I really wanted to bring you on the show today because you've dealt with a lot of change within your organization. We've had many conversations, and I think you've handled it so well. And it's very inspiring to so many people. And I think there might be people out there that may be struggling with change, or maybe working for an organization that doesn't support change, or, they want to do best practice and they feel unsupported. So I want to pick your brain. I just want to go through this and absolutely pick your brain. So let's start with what are the key indicators that indicate that you need to go through change, or how do you evaluate the need for change within your organization?
Evaluating change for me is, I hate to say it, it kind of starts with identifying problems and looking for trouble, just in full transparency. Looking for feedback, auditing practices, looking for spots that I'm concerned about or areas for improvement. Those are probably the thing that I start with most. I handle all of the incident reporting within the organization on both service lines. So it's terrible, but I love diving into that data. I love diving into those reports because they give you such a great idea for where you are as an organization and what you need to improve upon. And that's healthcare. There is always something that we can do differently, that we can improve upon, that we can take a look at. But I think to a certain extent, people are afraid of examining their own practices. I do think there is, in some areas, maybe a hesitancy or a fear of provoking change, because if you do that, you really have to take a look and see what we can do differently. And I think at times organizations are afraid to look at their mistakes and to look at their KPIs and their outcomes. I'm not sure why. Maybe it's a fear of liability or unwillingness to face what is going on. But I think you have to. And I find that the most exciting part, because if you do that and you actually look at, okay, I have this problem in my organization, maybe not even a problem, I have this thing that I want to improve upon. And you make the decision, that is what I'm going to do. You implement a project, you monitor the results of it, you educate the staff, and then a couple months later, you get to see the results of that. And that is the best part of my job, is being able to see the difference in our patient safety and our patient outcomes, or just our staff morale, education, and training that I can do by just taking a look and evaluating our current practices, our current successes, our current failures, and implementing something that can change all of that for the better.
I agree. I can reflect back and advocating for change and really being at the pitching side of things as the nurse at the table. Sometimes as a nurse executive, you're the only nurse at the table.
Yeah, you are.
And you have to put everything into logic to people who do not have a clinical mind. So let's talk about that a little bit. I can remember it being very challenging to get initial buy-in for individuals who maybe didn't understand how the clinical change was going to impact the organization in a positive way. What's your approach? What would you recommend for individuals who are pitching change because they have best practice and we need to see that within the organization or in general? What's the best tips or advice you can give someone?
For me, I always start by acknowledging the challenges that come with change. People are resistant to it, just things that they perceive as disruptive, they perceive as difficult, they perceive as unnecessary. It's hard. I mean, you absolutely have to overcome that hurdle. And I think to really overcome that, you have to recognize that first. So that's probably the first step that I go for, is understanding, this is going to be difficult. And then I move into why. Yeah. Why is this going to be difficult? So that, is going to be aligned with organizational or personal goals for whoever you're trying to encourage or motivate change for. So think about it. Okay. Is this going to be an additional cost? Is this going to require a ton of work? Is this going to require multiple people collaborating on a project? Am I going to need to get buy-in from one person, or am I going to need to get buy-in from 10 different people to enact this change? So I'm a very logical, methodical thinker. So that's how I start, is I go for, it's going to be difficult. Why is it going to be difficult? And after I do that, I really think I can break down and identify, how can I overcome that? So case in point, if it's going to be cost, I understand it. Absolutely. There will be cost associated with this change, this project we want to do. Okay. There's cost associated with it. This is the cost associated with a poor patient outcome. This is the cost associated with a clopsy, with a, phlebitis infection. This is how we can overcome that and what we can do differently. So it doesn't matter what you're doing to enact change. You kind of have to know how to speak to the people and figure out what their motivation is to get their buy-in for it. And different groups are going to have different motivational strategies. So there is going to be people that I can buy in by saying, this is a patient safety. This is a clinical outcome. This is staff morale that we need to work on. This is just industry standards that we need to align ourselves with. Whereas others, you're going to have to prove more, logical data points, price, cost points, what this is going to produce in the organization to get their buy-in. So I think that's probably the best way to go about and motivate change, is to understand what the person or people are going to be motivated by and how this is going to affect them. Past that point, getting buy-in, I think illustrating the successes of the project, even if they're small, but I mean, illustrating the positive outcomes of the change, it makes the transition.
As we get so strategic that we think about what we want and how perfect it's going to be when we get to that point, we forget about the small steps it takes to get there. So I'm so glad you're hitting on that.
Yes, absolutely. If you celebrate those small successes, I think the transition feels less disruptive.
Yeah.
And if it's a large change, less like, just a hurdle to get over, and more like an exciting evolution. And that is also something that I would recommend to people. You have to be the leader of the process. You have to be the cheerleader. You have to get excited and get other we excited about change. If you come at this with just like dread, this is what we have to do, it stinks, but we need to align with these standards, that is 100% going to be expressed to the people that you need to get buy-in for. You need to come across as completely motivated, completely excited about this. This is a wonderful opportunity. We have new growth. We have organizational goals that we can meet with this. And I think people can sense that, and they can absolutely sense it in healthcare when you're excited about something. So
especially if you really believe in the why and you express
yes,
the why.
yes, oh, Derek, that is key. You have to believe in the why of what you're doing. I really think for everything, not just change. But
Yes.
if you come to the table with, oh man, I just got to get this done, you're not going to be motivated. And no more are the people who are going to do a ton of work to get this change across the table, across that finish line. You have to be the expert on the material. You have to be excited about the material. Invite collaboration. If you can get other people, other stakeholders to buy into your idea, to buy into your success, that will do you a world of difference in implementing and motivating change within an organization. One person doesn't have to produce change, but that one person does need to motivate that change. It's absolutely key.
I remember being in practice before I was in leadership, and the key terms I heard so often is, well, we've always done it that way.
Oh gosh, yes.
Or we heard they'll never change that. Or we'll never get the funding to do this project. Or so and so, as long as they're the director, will always block. I mean, you hear all these things, and
you do.
In life, what I found out when I took and I leaped into leadership and got into some executive leadership positions, that was not always the case.
Oh, it's not.
Sometimes, I was speaking to the chief nursing officer. She would say, I never knew about this. I'm so glad you brought that up. And the reason why she didn't know about that is because people were scared to bring it forward, or although were complaining that they wanted to change, they never took the initiative to be solution driven.
Absolutely. That is such a great point. First off, I've heard that so many times, I can't stand that phrase anymore. It's just the way we've always done it. Anytime somebody tells me that, I'm like, that's not an answer. That's embarrassing. That's an embarrassing answer. This is healthcare. You got to change. You got to keep up. But yes, to your point, I do think there is certainly a hesitation to speak up and a belief that people won't listen. And you are exactly right. Like, the people on the ground, they're the ones that can make the difference. I can tell you, I've had so many people come to me and I'm like, that's a wonderful idea. I never thought of that. Like, had no idea. But now that you've brought it up, yes, let's look at it. Let's look at what we can do differently. Let's look at what we can change about this process. But to your point, I wouldn't have thought of that if they hadn't come up and spoke about it. You certainly, I love leadership. I love the ability to make a change in practice, to support our nurses, to support our patients. But once you get into leadership, you don't have the feet on the ground anymore. So you don't work with the same processes and see the same problems that, the bedside nurses or the field nurses do. And it is critical. It is critical for anyone who's doing that to speak to their leadership about that.
100%. And on the flip side, leadership to consider, is change doable? Is it practical? I mean, how many times have you heard this? You went to go implement something and it's like, well, who wrote this policy? And this can't.
Yes.
I mean, you heard that?
Oh my gosh.
I know I've gotten it a few times with writing policy. It's
so many times.
And some things were validated. You consider a certain perspective, or consider a certain resource that you are lacking, or it's never ending when you really thinking about this. But it can be very challenging.
It absolutely can. I've started, like, any of my big policies, I've started doing like little mini focus groups with the nurses, because you are 100% right. I have a great idea. I think this is going to save us time, money. I think the nurses are going to love this. It's going to be amazing. They're going to say thank you. And I get it rolled out there. And that first phone call, I'm like, oh, I totally forgot about this one detail. It's going to make this process
Absolutely.
completely unusable. Yes.
Yeah. And the most magical moment that could ever happen is if you can place both sides. So if you're able to pitch this beautiful change, get it through, get the appropriate resources, it maybe makes its way into policy. You implement that policy and the clinicians say, this is great. Can you imagine? That's like a perfect scenario. But how often does that happen? I mean, it doesn't, right?
Not very often. Not very often. I do think that
hurdles are
buy-in,
normal, right?
Yes. It's hard. Getting buy-in from nurses, though, from the nursing change, I'm going to say I think it's a little bit easier than executive.
Great. But I think that's your case because you do advocate and you listen.
Yeah.
You know, you're just talking about. You have your groups you're listing. You really want to focus on change that's going to be impactful for the patient, but also considering the nurses who are at the bedside practice. It's so important because we don't want to create change that is unachievable and creating failure, right?
Oh, absolutely. And, I do think people fall into that sometimes where they decide we have to change something, we have to conform with some way that we're doing this. But if you don't take into account the actual results and the actual outcomes, it's just worthless. You are not going to get buy-in from staff that whatever change you're doing, whatever process you're trying to implement, it's going to fail. I think that is the greatest indicator of failure, is making change for the sake of something without considering the people who are going to actually be doing or using it, or the patients.
And that's why that evaluation phase is so important. We can implement 6 months down the road. We thought it was beautiful on paper.
Oh, yeah.
We implement in 6 months later, we're reevaluating. Wow, that is not the expected. And that's normal. And that's part of nursing. That's part of change. And and I say this all because I want people to truly understand hurdles are to be expected. And we have to get hurdles. We have to continue to advocate for our patients and really advocate for that change because that's how we move the needle within care.
Absolutely. Absolutely. Change is difficult.
It's so hard.
We're having a whole conversation about it. Change is hard. You are going to face challenges along the way. You're going to face hurdles along the way. Getting everyone on the same page and aligning all the different constituents, all the different team members is going to be difficult. But I think if you approach it in a positive manner, and I hate to say it, a methodical, logical manner, you can hope to identify those hurdles beforehand.
And there's a real science behind it.
Yes. And it's true. And that is the science to change. The books about change, people need to read them. They really do, because it makes sense. It really does. It really does.
Speaking of change, you are presenting at INS about some change that you implemented within your organization. Do you care to talk a little bit about? We don't want to give away too much because you're presenting, and we want to keep all the good stuff for them at conference. But any information that you would be willing to share, maybe
I would love to. So I'll keep a little bit back, but I'll give you all the gist of it. So I recently, I guess it's been several months now, I had the chance to read the standards of care for peripheral intravenous catheters. So we had a chance, and I took a look at this, and this is a prime indicator of what everyone can do for change. Okay. We had something that is used so frequently in vascular access and infusion therapy. I mean, just every single day, this is a key thing. I hate to say it, it's almost so commonly used that I think it's a little boring for people. And I feel like maybe people assume we're tapped on that material. We're tapped on that discussion. There's not much change that is wrong. That is wrong. And this came out. So I took a look at that.
Talk about that document in case any listeners have not read that. That was endorsed by 16 organizations, including ABA, INS. Many thought leaders came to the table, and they determined that there needs to be a comprehensive document combined using the INS standards of practice, but also incorporating expert consensus. It's a really cool document to be able to reference and see all those different domains and how they're applied to your practice. But anyways, just to give a little bit more relevance to that, go ahead.
I'm telling you, like, y'all need to check it out. I was very excited. I was very, very excited when it was sent to me. But case in point, I took a look over it, and I'll be frank with y'all. Our organization, prides itself on staying up to date on care practices, patient outcomes. So there was the majority of we already did. They were already in our protocols or policies. They were very common, not really contentious, but I did find 3 that I thought we had a clear opportunity to make a real difference in our patient care.
3 domains that you focused on?
3 domains that I focused on. I'll share a little bit about them. Okay, just tease, because I do want people to read this. So in particular, pain reduction and comfort strategies was one, maximizing first insertion success. And then the very contentious principle of removing and replacing peripheral IVs only if necessary. So these 3 domains I thought would work best for our organization and allow us, back to the very beginning, what can you do differently within your own practices, would give us a chance to take a look at what we needed to approach and how we needed to enact change within our own organization. So I'm speaking on it on INS, but I can tell y'all that it was a very, very cool project to be involved with, that allowed us to kind of take an internal assessment and identify areas where we could make improvements. And then it had some really awesome outcomes and things that I thought had results that were overwhelmingly positive.
And results, did you anticipate the results that you received?
Some yes and some no. So, I had hope. I'd hope for results, which I think is what you always do when you want to enact change. So obviously hope for fewer complications, reduced patient outcomes, better first attempt success rates with catheter insertions. But kind of one that I'd hoped for, but I didn't anticipate was I did see a distinct amount of staff morale improvement. And that's the best thing about leadership. And what I think people forget, the more that you help your nurses, the more that you provide education, you provide skills, you provide training, the more confident they are in their own practice and in their own skills. And that was probably the one piece that I was pleasantly surprised for, was the amount of excitement around this project in what, to be blunt, I thought was going to be I'm going to need to get some buy-in from the nurses. They always do peripheral IVs. This is a normal thing for them. No, they were really excited. They were excited for new evidence. They were excited for new education. They were excited for change, because it allowed them to significantly improve their patient care. And at the end of the line, nurses want to take care of patients, and they want to take care of patients well. So if you provide them with the tools to do that, makes a huge difference for them. And I was beyond pleased at the response that they gave me.
That's awesome. I can't wait to hear more of this at conference. So if you haven't registered for conference, we highly recommend that. Go ahead and get that done, because you get to meet people like Taryn and many other thought leaders that are really making change, new evidence that's really going to help move the needle within therapy. So again, just to plug a little bit, but if you've not registered, be sure to do that, because you don't want to miss this session with Taryn and Marlene, who was one of the authors of the document and is our director of clinical education here at INS. So it's going to be a powerful dynamic between the two. I'm excited for it. So I really thank you, Taryn, for joining us today. I think this was a really impactful discussion. And I think there's a lot that can be taken from this, from many clinicians, leaders who are listening. But do you have any final words before we wrap up today's episode?
No, I have to say thank you so much. This has been a ton of fun. It has been it's always so much fun to talk about infusion and to your point, moving the needle in infusion therapy and some changes that we can implement. But if I have to leave anyone with any words of encouragement regarding change, it is about making a tangible difference in the lives of our patients and our staff. And it is something to be excited about. It is something that everyone from bedside nurses to leadership should encourage. We want to progress as nurses. We want to progress in healthcare. And you can't do that if you stay stagnant. You need to continuously learn and continuously evaluate your practices. And you can have a lot of fun with it as you go on.
Well, thank you. And thank you all for joining the INS Infusion Room today. Today's infusion of knowledge titled Implementing Change into Practice with our expert guest, Taryn Lee, has provided us with valuable insights. I'm your host, Derek Fox, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.